So I'd like to talk to you a little bit today about how flu vaccines are made. And as I was kind of constructing this talk, I actually started remembering one of my favorite shows, which is How It's Made. And so hopefully this is going to be like a fun little like how it's made about flu vaccines. So I just wanted to explain to you a little bit what I'm going to talk to you about. I'm going to talk a little bit about flu virus itself. Then I'm talking a little bit about the vaccine, and then hopefully how we can even make the vaccine a little bit better and kind of where we're like hoping to go from where we are today. So I first want to put you guys in the position of where I probably was a little bit ago, where okay, like we know the flu shot exists, and we know that like flu is a thing, but maybe we had an illness and we thought it actually wasn't that big a deal. Like, I've had the common cold before, why do I have to get a flu shot every year? That seems like a hassle, and also shots hurt and I don't like needles. So I'm going to talk to you a little bit about the flu virus and why it's really good to get a flu vaccine. So when we say flu, we actually sort of colloquially, I think, mean a lot of different things. And one of those things is kind of a common cold, like a head cold. And those viruses are actually, the ones that cause the common cold are usually rhinovirus, human metapneumovirus, adenovirus, these other kind of seasonal coronaviruses that we're familiar with. Usually they're not influenza virus. And another thing that people mean when they say the flu is something slightly different. It's an enteropathogen, and that could be caused by any number of viruses and some bacteria, including norovirus, rotavirus, and then of course Salmonella and E. coli also. And what I'm actually talking about is influenza, and usually influenza infection kind of means you have fever and you have chills, you have body aches, extreme fatigue. Your illness will last 1 to 2 weeks. And I'll talk a little bit more about this later, but you also have an increased risk of blood clots during this time. In general, it feels like you got hit by a bus. It's really unpleasant. For those of you who have had flu, it's just really, really unpleasant. And the amazing thing is that this is a vaccine preventable illness. So rather than being in bed miserable for 2 weeks, you could not do that. So that seems like a really great option. And I actually really like this graphic from CDC. It kind of helps you compare influenza and then common cold symptoms. And I will say, for example, headache, for example, in influenza is really common. For common cold, it's rare. Fever is very common for influenza. For a common cold, it's rare. So just really keep in mind that when we're talking about influenza infection, it's really something a little bit more severe than the common cold type thing. So now I'm going to move on a little bit to what I would have thought around 2009 when I was just beginning my master's program in public health. I remember saying out loud during a global flu pandemic, why are we even studying flu? Barely anyone dies of flu. Flu's boring. There's plenty of other more interesting stuff out there. And I'm glad that I got to be proven wrong about this. So normally, what I'd tell you is that influenza is one of the likeliest causes of a global pandemic. And then I'd try to sort of scare you about, the fact that a global pandemic is a very real possibility. But of course, we all know that that is a very real possibility right now. So I won't go too far down that road. Instead, I'll just explain to you that influenza is really likely to cause a pandemic because it makes a lot of mistakes when it copies itself. And something that I like to say is that it's kind of like the Forrest Gump of infectious diseases. It makes mistakes and it sort of happens to accidentally do a lot of things that turn out to be really good for it. The other thing is that it's also pretty transmissible. You all have been hearing about this number R naught. That's the number of people that one person can infect in a totally susceptible population. For flu, we think this is between 1 and 2 other people. And anytime that number is above 1, it's possible that we can have a sort of a large-scale epidemic or pandemic. So that's something that's also really of high concern to us. And then the other thing that's really concerning about flu is that it can infect way more animals than just humans. And hopefully you can see a couple of these different animal outlines. We've got lemurs, we've got cats, there's frogs, there's whales. A lot of different animals in the animal kingdom can get influenza. And for these 4 black circles here, wild birds, humans, and then poultry and swine, those black circles indicate that the virus is capable of recombining within those hosts, and those hosts include us. What I mean by recombining is We can get more than one different virus infecting us at the same time. And those viruses can swap genetic material with each other and combine and make a new virus. And that's what happens a lot of the time when we have pandemic viruses. In fact, our 2009 swine flu pandemic was a recombinant virus. So we're understandably quite nervous about the potential for an influenza global pandemic. It's a more severe illness than the common cold, and it's bad to have pandemics of it. It affects younger children and older adults, which are typically sort of vulnerable populations that we really want to protect. And it also has this really kind of unique other sequelae outcomes besides just having a respiratory illness. For example, it's a major cause of myocarditis, which is an inflammation of your heart muscle. And it also can cause something called Guillain-Barré syndrome. Guillain-Barré syndrome is a deterioration of the protein sheaths around our nerves. You can see here we've got this nice myelin sheath at the top. That helps the nerve signals travel really fast down our nerves. And at the bottom, you can see that that myelin sheath is deteriorating. And that can cause numbness, tingling, and also paralysis. It is reversible in many cases, but it's very unfortunate and it's very upsetting, of course, if you have it. We really want to avoid that as much as possible. And I just want to go a little bit more into influenza in the heart. What's really, truly amazing to me about influenza, one of the many things, is that you can be up to 6 times more likely to get a heart attack in the week after your flu infection than at any other time. So you can kind of think of a vaccine against flu as being a vaccine against heart attacks as well, which is pretty amazing. If you're interested in that, there's more information in this article, so you can feel free to click on that later. So I really want to sort of underline, I know that we have a different global pandemic going on right now, but really nothing compares to flu in its sort of uniqueness and its sort of little idiosyncrasies. So hopefully I've gotten you interested about flu and why I think it's so important that we have a vaccine for it. And I just wanted to explain to you a little bit about its extended family. In general, there's influenza A, B, C, and D. We get protection from A and B in our yearly vaccines. And influenza C and D don't cause as much disease in humans, although you saw that slide with all of the animals. Certainly it can infect other animals. There's several different subtypes of influenza A and influenza B, and they're always changing. That's that kind of Forrest Gump situation. And so that's one of the reasons why we need a flu vaccine every year. So I wanted to talk to you a little bit about the structure of the flu virus. As you can see, there's a lot of information here. So I'm just going to focus on 2 main parts. One of them is the neuraminidase, which is one of those transmembrane proteins, and the other one is called a hemagglutinin. And that's this blue one. So these are both little proteins that are stuck into the membrane of the flu virus. And they're kind of the main targets for our immune system. So when we see a flu virus, these neuraminidase and hemagglutinins are usually the 2 things that our immune system reacts against and say, hey, you know what, I'm recognizing this. This part tells me that this is a flu virus. This part is the part that I'm going to form antibodies against. So one of the things that's so challenging about influenza is that there's 18, that we know of, 18 different types of hemagglutinins and 11 different types of neuraminidase. And so there's a ton of different combinations that we can have of different influenzas. When we think about 11 times 18, that's quite a few. And in case you're wondering, that's also how we get our naming conventions for some of the influenza A viruses. For example, H3N2 means hemagglutinin 3, neuraminidase 2, and H1N1, sort of same situation. So now you know what those H's and N's stand for. And because the shapes of these hemagglutinins and neuraminases are always changing and they're switching up, we kind of have something called an influenza archipelago. This is a really fascinating paper, and I actually really recommend that you check it out if you have a little extra time and you're kind of nerdy about infectious diseases like me. But I'm going to use this little picture of this influenza archipelago to explain the concepts of shift and drift. So this genetic drift is a little island hop. So, you know, you can think of it as like a very small change from one virus to like, maybe the next door virus. But a shift is a bigger change. It's a flight to the next cluster of islands. And the further we are away from the last island, the more likely our immune memory from the last island won't help us out. So, for example, antigenic shift, which is this bigger flight to the next cluster of islands, is something that we're really concerned about. It's another thing that can increase the possibility of a global pandemic of influenza. So this is why we keep having to have new flu vaccines, which I know is really annoying. It would be great if we could only have one flu vaccine forever, and I will talk about that a little bit at the end of this. So predicting the next island that we're going to go to is a big part of identifying what should be in the flu vaccine next year. And as you can imagine, this is extraordinarily challenging. The World Health Organization is looking for flu cases all the time throughout the year. And this is a kind of map of where they are right now. Sorry, not right now, from September 2017 to January 2018. You can see that it actually really depends where you are in the world, what might be circulating. So in some areas, for example, in South America, we're seeing a lot of influenza B. In some other areas, for example, in Northern Africa, we're seeing a lot of influenza A. So it really depends on where you are. It could change from year to year. It could change within the season. It could change based on the population at risk, etc. And so that's one very challenging moving target. Another challenging moving target is antigenic characterization. And by that I mean, how similar is the circulating virus to the virus that we're protected against in the vaccine? So this is two different hemagglutinins, and you might be able to see they're slightly different colors, but more or less they're both blue, they look the same. So we might say, they're a little bit different, but they're not different enough that our immune system won't recognize both of them. But if one of them is really different, if one of them is blue and then one of them is yellow with polka dots, then we're going to have a harder time identifying that it's the same thing that we're supposed to be protecting against. So the further away that virus is from what we saw in the vaccine, the less likely we are to be protected against it. We also investigate viral fitness, and this is another sort of moving target. And what I mean by viral fitness is how good the virus is at reproducing itself and how good it is at making you feel miserable. So viruses with poor fitness that are not good at replicating or not good at transmitting to other people, they're less likely to cause big-scale problems. And viruses may be less susceptible to antiviral medication. So this is a good thing for viral fitness, but a bad thing for us if they don't respond to antiviral medication. So that's also really good to know about and something that we sort of incorporate into the vaccine formulation. Okay, so now that we've got all of these different, really challenging moving targets, all of this information goes into constructing the vaccine. And there's actually a strain selection committee meeting that happens at WHO in Geneva every year. So this is a meeting of epidemiologists, virologists, mathematical modelers, flu vaccine manufacturers, ministers of health of different countries, a lot of different people that all look at influenza from a different sort of perspective and a different angle, working together. And for the vaccine, they work together during this committee meeting to select 2 flu A subtypes and 2 flu B lineages. So that means that there's 4 strains in total in your vaccine. And if you're wondering what is a subtype, what is a lineage, that's just kind of a subdivision of influenza A. For example, if we have 2 influenza A subtypes, one might be an H3N2 subtype, one might be an H1N1 subtype. And I can talk a little bit more about that if folks are curious later on. The other thing that we discussed during this committee meeting is what vaccine strains can be grown quickly in eggs. And I did say eggs. We make a guess in February about what we're going to need in December of that year. And then we have 10 months to make enough flu vaccine, which is hundreds of millions of doses. We want people to get vaccinated before the flu season starts, so that even shortens the timeline a little bit more. How on earth are we actually going to achieve this? This really seems incredibly challenging, especially given what we know about vaccine development and what we're seeing now with COVID-19 vaccines. We know it takes a while. We know we need time not only to make sure that the vaccine works, but also to make sure that we have enough doses for everyone. And we've shortened our timeline by needing people to get vaccinated actually before a flu season starts. So how do we do this for flu? We literally grow the flu vaccine viruses in chicken eggs. And I really mean literally in actual chicken eggs. So you can see, I just wanted to show you an actual picture of a chicken egg being inoculated with a flu vaccine virus. So once they're grown in chicken eggs, we harvest that antigen, and then it's purified and put into vaccine vials, like the one you see here for Fluzone. Oh, sorry. And then it's delivered to people. So I want to tell you a little bit more about what the WHO said this February. So this is information that's available on the WHO website if you're curious. For the Northern Hemisphere, they recommended these two influenza A strains, one H1N1 and one H3N2 strain, and two influenza B strains. This is a 1B Victoria and 1B Yamagata lineage. So we've got 4 different things in our flu vaccine this year. And it's also worth noting, just in case this is interesting to everyone, you remember that map that I showed you a few slides ago with different, flu viruses circulating in different areas of the world? We actually sort of have opposing times of flu epidemics in the Northern Hemisphere and the Southern Hemisphere. So the Southern Hemisphere Strain Selection Committee meeting meets at a different time. They decide on a different time scale, and then their vaccine usually has different antigens in it. Okay, so what about vaccine effectiveness? And I want to say, unfortunately, flu vaccine effectiveness is not as great as some other vaccines. I wish I could tell you that it's 99%, just like some of our other vaccines, like our measles vaccine dose. When you complete the dose, you're really very highly protected. Unfortunately, for flu vaccine, that's not quite the case. We don't get quite there. But when you consider how often flu changes and all of these other moving targets, it is pretty amazing that it works as well as it does. In an average year, if we're lucky, we'll get about 60% effectiveness for H3N2 strains. And if we're really lucky, we might even get higher effectiveness for H1N1 and B strains. But that's kind of in an ideal scenario where we have really good antigenic match, where people get vaccinated at the exact right time, and we really are able to record all of those flu infections that do and don't happen. Unfortunately, in some years, the vaccine is mismatched to the circulating strain. So that means that there's not good antigenic match. Instead of the 2 slightly different colors of blue hemagglutinins, we've got 1 blue hemagglutinin and 1 yellow polka dot hemagglutinin, and our immune systems just really don't make the connection. So that can cause low effectiveness. In some other years, the vaccine strain might be well matched, but the vaccine itself doesn't produce a lot of antibody. So our immune systems might look at the vaccine and go, you know what? We've seen it before. I'm not impressed, and I'm just gonna go back to sitting on the couch. I'm not gonna have a real big, robust response to this, and that also causes low effectiveness. We don't have a lot of antibody after getting vaccinated. You might say that's unfair. Yes, I agree with you. It is unfair. This is part of the price that we pay for trying to vaccinate against a disease that is constantly changing in a bunch of different ways. Although hopefully I've convinced you that it's worth it to try anyway. And it's also why we're so interested in something that's called a universal flu vaccine. I mentioned before, it would be so great if we could have a vaccine we only get once for flu. So I'm going to tell you a little bit about the structure of a universal flu vaccine. There are a lot of different potential strategies for developing a vaccine for flu that you only have to get once. And one of the biggest ones is a vaccine that focuses on this hemagglutinin. And I just want to explain to you that there's 2 kind of main parts of this hemagglutinin. There's a head part, which is the part that we usually form antibodies to, and that's the part that's in our current vaccine. It's also the part that's constantly changing, which we don't want. There's also a stalk part. So you can think of this as maybe like a mushroom with like a cap and then like a little stem. The stalk or the stem part is the part that we usually don't form as many antibodies to, but it changes way less, which is actually really good. So a lot of the structure of universal flu vaccines that are in development try to get us to form antibodies against the stalk of the hemagglutinin. And I also want to add here, and you will be maybe a little bit more familiar with these than you might in an average flu year, but there's also these non-pharmaceutical, non-vaccine interventions to prevent us from getting flu, and they work great. And one of those is covering your cough. This year, we've all got masks now, so that might be another really great option, as well as carefully washing your hands. And I wanted to also give you this. This is not something that I immediately understood the language for, but once I looked at the pictures, I actually was able to really understand exactly what all of these different things are saying, how the virus is spread, what you can do to stop that onward transmission. washing your hands and wearing a mask is really great. So I just wanted to show you that because I wanted to add that I think it's not necessary to use words in order to sort of illustrate how effective these interventions can be. So with that, I'm gonna stop talking and sort of ask if you have any questions. And I have a couple of other slides if you have specific questions. But otherwise, I'm very happy to answer any questions directly at this moment. Yeah, I see. If I get a flu vaccine in one country, but will travel to another country for an extended period of time during flu season, should I get a different vaccine than the one recommended for my home country? That's a great question. So in general, if you're traveling within the Northern Hemisphere, that flu vaccine will be the same. It will have the same antigens in it. If you're traveling from the Northern Hemisphere to the Southern Hemisphere, you might consider getting another flu vaccine because the Southern Hemisphere one is different. But keep in mind that the Southern Hemisphere epidemic also happens at a different time. So you might think about the timing that you need to have if you're traveling from the Southern Hemisphere to the Northern Hemisphere or vice versa. I see another question. What is the difference with a flu vaccine that's recommended for seniors? There's a couple of different types of flu vaccine. I actually didn't get into this very far. The most common one, the one that most of us get, is a regular dose, quadrivalent, meaning that there's 4 different strains in the vaccine that's grown in chicken eggs. But there's one for older adults, people over 65 years old, that's a high dose vaccine. So that means it has 4 times the amount of antigen. In general, that seems to be really, really good for older adults, and it seems to protect them much better than the regular vaccine. And I would recommend that if that's something that's if that's an option that's available to you. Mark, I saw your question. Is much progress being made in developing flu vaccine on other platforms such as mRNA to reduce manufacture time? Yes, so there's another thing that I sort of didn't get to today is manufacturing flu vaccine in cells rather than in chicken eggs. Cell-based influenza vaccine manufacturing seems to have a really promising future, but it's it's a small manufacturer right now. I think only one company does it, and so it's not big enough to supply like all of the pharmacies and all of their orders in the US, unfortunately, at this point. In terms of other platforms, in general, because of the way that we construct flu vaccine and we're sort of like reconstructing it every year, with a seasonal flu vaccine that we have to get every year, it's probably still going to be the case that we have this inactivated virus rather than like an mRNA. But I think that you've brought up a really great point that it's going to be, I think we're going to look at a lot of different modalities in the future, especially now that we're considering all of these other modalities for COVID-19. I'm seeing a question, will COVID vaccine research change how we develop flu vaccine in the future? Yeah, I think, so that was a great timing for that question. I think I kind of like already mentioned that a little bit in my response to Mark. I do think that once we learn a little bit more about the viral vector vaccines and the mRNA vaccines that are being used for COVID-19, that might encourage us to think innovatively about flu vaccine in a way that we haven't had to in a while. So I'm hopeful that we'll sort of be inspired by this process. Brandy asks if we could do multi-dose vaccines to increase protection. That's such a good question, Brandy. Actually, I saw this question on Twitter a little bit earlier in the week. So I'll give you the best answer that I can, which is not a yes or no answer, and it might be a little unsatisfying, I'm sorry, but I'll hopefully get you sort of excited about the question rather than like really getting to answer it. So at present, more than one seasonal flu vaccine in a season is not recommended. It's not a safety issue. It's just not, we just don't believe that it provides like a lot of extra benefit. And another really challenging thing about that is timing that second dose appropriately so that you get the maximum number of antibodies at the exactly right time during the flu vaccines or the flu season, which is also very hard to predict exactly when it's going to peak. So that adds kind of like an extra layer of challenge. As I mentioned, with older adults, they're getting 4 times the amount of antigen if they receive the high dose vaccine. So that's almost like getting 4 regular vaccines, but all at the same time. For older adults, we know that in general, their immune systems don't respond in the same way that younger adults and children do to the flu vaccine. And so that's why we think that it's really good for them in particular. But we also want to make sure for younger adults and for children that we're really adhering to this line where we want people to have a maximal immune response, but we also don't want them to get a fever. We don't want them to be uncomfortable. We don't want sensitivity at the injection site, all of that sort of thing as well. Another couple of thoughts about that. So children are not considered to be vaccinated until they've received 2 doses of a flu vaccine for their first time being vaccinated. So that's also something that we really consider to be important for your first time being vaccinated. I think it's likely that this question is going to be asked more seriously of younger adults in the near future, Brandy. And I think it's going to be a question about, is it logistically feasible to get people into a clinic twice in a flu season? And if so, how best can we time that so that they're maximally protected during the peak of the epidemic? Barry asked, if I took the senior one today, how many months of immunity would it probably give me? Probably about 6 to 9 months is my guess, Barry. But hopefully I've also explained to you that answer really depends on a lot of different things, including the shape of the epidemic, what's the majority circulating strain, if there's good antigenic match, and all of those other kind of things. Priya is asking, I read that it's best to avoid taking non-steroidal anti-inflammatory drugs for the week after receiving the flu vaccine because they may reduce your body's ability to develop immunity. Is that accurate? That's a great question. I hadn't seen that in the literature. But in general, the way that vaccines as a whole work is that they're kind of like an irritant to our immune system, and our immune system then responds by developing antibodies. We know that if we have an increase in inflammation in the sort of like earlier on immune response to the vaccine, we believe that probably provides a little bit more protection in terms of antibody later on, or probably it's a marker of more protection from antibody. That being said, I don't think that a really unpleasant inflammatory response is necessary for a good, robust immune protection against flu. So if you get a flu vaccine and you're really uncomfortable, you have a headache, or if you get a low-grade fever and you just feel like junk, I think it's fine to take a Tylenol. Thank you for liking my Prince joke. I love joking that joke, and it's a real lame joke, but I really think it's funny, and I keep doing it just in the hopes that someone will like it. So thank you, Priya, for feeling my Prince vibe. Other questions that I can answer.
I have a quick question. Could you speak to the so many different kinds of vaccines that are being developed for the coronavirus? Which ones are most likely to succeed, and maybe the differences among them?
Oh, that's a very, very good question. So yes, and I'm sorry, I saw Priya had another question as well. So Priya, I'll come to that right after this question. So yes, as you may have seen, maybe you've been on the New York Times vaccine tracker website. There's a ton of other vaccine tracker websites as well. There's even websites that track the trackers because there's so many trackers for COVID-19 vaccines. The latest count of COVID-19 vaccines in development is more than 100. And they're all at various different phases of clinical trials. The ones that are a little bit closer to potentially being licensed are viral vector vaccines, and there's an mRNA vaccine as well. And those, the reason that those are a little bit closer to licensure is that those types of vaccines are usually a little bit quicker to produce and develop. So I'll just explain a little bit about those types. The viral vector vaccines basically hijack a virus that we already know exists, and that doesn't cause us very much like inconvenience when we get infected with it. And then we take some of that genetic material of that virus and we replace it with the genetic material that codes for a specific protein or component of a virus that we want to vaccinate against. In the case of COVID-19, it's the spike protein. And there's one other protein that I'm forgetting. You'll have to forgive me at this point. So when those viruses invade our cells, they hijack our own cells to read that genetic material and produce those proteins. And then when we see those proteins, our immune system goes, wait a minute, that didn't come from here. That's not us. We're going to develop antibodies against that specific protein. And then when we see that protein in real life on the surface of a COVID-19 virus or SARS-CoV-2 virus, that's when we're able to sort of issue those antibodies that we already developed. With mRNA, it's actually not spliced into a viral vector. It's just given as genetic material. So that's it's kind of similar in that way. I hope that I answered your question, but I may not have. So whoever it was that asked that, please let me know if you have a follow-up.
The only follow-up would be is if you have an opinion as to which type would be most effective.
Oh, I see. That's a great question. I don't have an opinion as to which type might be most effective. I think as a scientist, I have to look just at the clinical trial data, and I'll make my decision on based on what I see reported in the clinical trial, based on their measures of effectiveness and also their measures of safety. So I'm really looking forward to seeing those numbers. Priya asked, is it ideal to wait until mid-fall to get vaccinated? In general, there is some evidence that suggests that there may be waning of immunity within an individual season of flu, which is really not great. We would love to be vaccinated, for example, in like July, September, and have that protection last us all the way through like maybe March of next year. It seems as though, especially in some seasons, there may be some waning of immunity. So you're, really highly protected 2 weeks after you get the vaccine, and then maybe by the time 6 months later rolls around, you're still protected, but maybe not as much. This is kind of a dangerous game to play, though, because we also find it very challenging to know exactly when a flu season is going to start and exactly when the peak is going to happen as well. So I would say the ideal situation is to get a flu vaccine. If that means, one day you're thinking about it, CVS is right there, they've got no line, I say that's the time you should go. Make it so easy for yourself that it almost is an accident that you get a vaccine against flu. But if you have all the time in the world and all the energy in the world to get that flu vaccine, maybe you're really looking forward to that Publix gift certificate, then I would pick sometime where, especially during this season, sometime where there aren't lines, where you can socially distance and safely receive the flu vaccine without sort of exposing a lot of other people to you and without exposing yourself to a lot of other people. My answer might be different in a different year, but that's the answer for this particular year. I hope that's helpful. Has consideration been made to dosing with 2 quadrivalent vaccines at the same time? Or is this cost/time prohibitive? Or would this prevent a good immune response to any one vaccine? Okay, so yeah, so this is maybe like 2 different questions about safety and effectiveness. In terms of effectiveness, Brandy, what you might be talking about is something that we call the prime boost effect. So for some vaccines, we have multiple doses because the first dose kind of primes our immune system to it. You have like a reaction, that's kind of like a medium reaction. It lasts like a little bit longer over time. And then later on, when we're done having that reaction, we get another vaccine and our immune system has recognized it. And then it has a really robust reaction and like produces a lot of antibody. And that's the boost effect. Whether or not there's a prime boost effect for flu vaccine is really a little bit hard to tell. It seems like there is that case for children, which is why we ask them to get 2 doses in a year if they've never gotten the flu vaccine before. Is it cost/time prohibitive? I don't think that it's cost/time prohibitive. We do a lot of different, especially nowadays, we're doing a lot of different things that we might not have otherwise planned for, but we have really no other choice to do it safely. I think it's something that's important to consider. unfortunately, there isn't very much research on regular, sort of otherwise healthy adults of all ages receiving 2 flu vaccines in 1 year and what effect that may have in terms of both effectiveness and also safety. I think it's a really good question, Randy. I think it's the sort of question that maybe I should be asking as well. 1 egg, 1 dose of vaccine? No, 1 egg, several doses of vaccine, which is why actually we bother growing them in eggs. Eggs are very good at growing things, and so that allows us to be really judicious with the resources that we have. Are the chickens that create the eggs for vaccine production specially raised for this purpose, or some special strain, or are they the types that make omelet eggs? I think these eggs are fertilized. So they're not omelet eggs, at least hopefully they're not your omelet eggs. But in any other sense of the word, they are chicken eggs. And so if you were to get to them before they were fertilized, you probably could put them in an omelet. They're probably specifically for vaccine production. And there's very likely some additional considerations when you're raising poultry about, the sterile environment that you have to keep for your poultry, how the eggs need to be cleaned before they're delivered to the lab and that sort of thing. But for those of you who have worked in a hen house, you may know that there's already sort of biosecurity protections, especially in bigger poultry operations for those chickens as well. So yeah, there's a lot of similarities between those eggs and in your omelet eggs. Just an FYI, CVS requires an appointment for the flu vaccine this year. Thank you, Lucien. That's really great to know. I didn't know that. And that makes perfect sense. It's actually a really great way probably for you to both make a plan and stick to the plan, and also make sure that you're at CVS at a time when it's not every other person in your neighborhood at CVS at the same time. This week, the clinical trials for one of the potential COVID-19 vaccines was halted due to the illness of a trial participant. Yes. How common is it for a trial to be stopped due to illness of a test subject? It's actually more common than you might think. And I actually want to talk about this a little bit in case people are interested. So before we start doing any of these trials, we set some rules for ourselves about what exactly we're going to do and what kind of data or outcomes will force us to make a decision of X or Y or Z. So for example, if a participant in the study has an unfortunate side effect or some kind of health outcome that we think possibly, even if like very unlikely, it's still theoretically possible that it could have been related to the vaccine, then we stop the trial and we thoroughly investigate before we move on. It's a very safety-oriented process. So when people are participants in these trials, and some of you may have been participants in clinical trials before, you're given a diary and you're asked to write down everything in that diary about how you're feeling. If you had a headache and you took an aspirin, if you were sneezing and you took some Claritin, if you woke up tired one morning. And not only that, but study investigators then are also calling you on the phone, or maybe they're meeting you in person sometimes to ask you, hey, like, is there anything you forgot to write down? And so anything that is serious and even remotely possibly related causes a full-scale investigation. And as you can imagine, some of these things turn out to not be related. But it's good that we stop just in case so that everyone else who's participating in the trial, we can make sure that they're as safe as possible. I hope I answered your question, Rai, but let me know if you have a follow-up. And Mark, thank you so much for posting those links for signing up for a COVID-19 trial. I know there's a couple of different studies going on at Emory right now as well. And some of those folks are folks that I worked with while I was a postdoc there at Emory, and they're really wonderful people. So if you have the ability and the time to volunteer, I know it would be extremely highly appreciated.
I will just allow a few more moments for any last questions.
Mark, if you enter the word Leon, does that mean that you get a free tote bag?
It's oh, here's a question.
Oh, once the egg is inoculated with the virus to develop the vaccine, how long does it take for the vaccine to grow in the egg? Not that long. It depends on the depends on the formulation. And actually, one of the other considerations is how well that vaccine virus will grow in an egg. So that's part of the discussion that happens at WHO during that strain selection committee meeting. There may be a really good match, but it might just grow really slowly in eggs. And that might be sort of like removed as a candidate just because it grows really slowly. You know, I'm not sure. Oh, Mark, that's a great tote bag. That's amazing. I was really joking, but that you were right. That's absolutely a great tote bag. I'm a bit jealous now. Right. Sorry, I wanted to tell you exactly how many days, and I actually don't know the answer to that. I think it's a matter of weeks. Yeah, 1 week, 3 weeks. What time frame? I think it's 2 to 3 weeks. But I will. Do you know what I'll do? Is I'll double check, and I'll post on the YouTube link to follow up on that. You're welcome.
All right, thank you so much, Maria. That was fantastic. I want to remind everybody, go get your flu vaccine if you haven't already figured that out today.
Please get a flu vaccine.
Subscribe to our YouTube channel. You'll get a notification of this video and our upcoming videos. If you missed them, we'll post them there and you get to watch them. Of course, we post all the links that we mentioned and drop in the chat here. On our Science for Georgia website, you can sign up for our newsletter, leave a donation if you'd like. You can check out our upcoming events. And don't forget, we dropped that link to the poll. If you want to let us know how we did today, just click through and fill out that form. All right, Maria, do you have any last words?
I just want to thank everyone so much. I would love to be, at Manuel's Tavern right now, and instead of that, I'm here in Toronto in my friend's apartment. But it's just really great to be able to talk about science with you guys, and I really, really appreciate the time and interest that everyone has. So thank you so much for including me in this.
All right, everyone have a great weekend. Stay safe, get your vaccine, and we'll see you at our next virtual science event.
Bye, everybody.
Bye.